Hello, my name's Sarah Oakley. I'm a nurse, health visitor and international board certified lactation consultant, and I specialise in tongue-tie division. I'm also the author of the book, Why Tongue-tie Matters. I'm going to talk to you today about posterior tongue-tie. This is something that causes a lot of confusion for parents and professionals alike, and it's largely because there are no clear definitions when it comes to tongue-tie. The terms anterior and posterior are bandied around, but they mean different things to different people. So basically, if something is anterior, it means it's close to the front, and if it's posterior, it's close to the back. So an anterior tongue tie is a tongue tie that's attached close to the tip of the tongue and is very visually obvious. A posterior tongue tie is a tongue tie that's attached further back and is not so visually obvious. Now, the point at which an anterior tongue tie becomes a posterior tongue tie is where the problem starts. In many of the research papers, they refer to tongue ties as being posterior if they're attached more than halfway back along the undersurface of the tongue. But many of us who actually divide tongue ties would say that they are all anterior unless they're attached right at the very base of the tongue. And those tongue ties that are attached right at the base of the tongue, previously termed submucosal tongue ties. So for many years, in my own mind, in the mind of many practitioners, when we talked about anterior ties, we were talking about anything that wasn't at the base of the tongue, that wasn't submucosal. Now, submucosal means under the lining of the mouth. That in itself is a little bit of a misleading term because all tongue ties are covered in mucosa. So they all have a mucosal layer. And that has been confirmed by the work of Nikki Mills in New Zealand that was published in 2019. All tongue ties will have that mucosal layer. So all tongue ties technically are submucosal. But the whole concept of submucosal tongue ties came about in the United States in 2004 and was first described by a doctor called Betty Carollis and a lactation consultant called Catherine Watson-Jenner. And what they found was when they were treating tongue ties in babies, they found that when they divided those tongue ties, quite a lot of the babies seemed to have tension right at the base of the tongue. And some of those babies had that tension behind the anterior tie, and some of those babies didn't have an anterior tie, they just had this tension at the base of the tongue. And their theory was that the lingual frenulum, which is the stringy bit that extends from the undersurface of the tongue down into the floor of the mouth, that is a normal anatomy, their theory was that frenulum extended back underneath the line of the mouth and into the base of the tongue where the genius glossus muscle is. And that actually the tightness and the band of tissue that they could feel at the base of the tongue was a kind of buried frenulum that was situated almost within the genius glossus muscle. We now know from the anatomical studies that have been done by Nikki Mills in New Zealand that actually isn't how the anatomy of a frenulum works, and that actually lingual frenulums are a layered structure, and they have three layers. They have, on the outer layer, they have the mucous membrane. Then they have fascia within that, and then beneath that is the genius glossus muscle. So a lingual frenulum is like a fold of tissue that comes out of the floor of the mouth, and the outer layer will be the mucous membrane. Then there'll be fascia going up inside it, and then right at the base there's the genius glossus muscle, which is the big muscle at the base of the tongue. And in with some lingual frenulums, they are just going to be very thin and membranous, and it is just literally mucous membrane. But most will have a little bit of fascia inside them. Some will have fascia right up into the fold, and some of them are so tense that they pull the genius glossus muscle up inside as well. So with the submucosal tongue ties, what we now believe is happening based on the anatomical research is that the tension that you're feeling at the base of the tongue is actually not a lingual frenulum. It is actually simply muscular tension. And what was being clipped previously may actually just be the septum, the dividing wall, which goes up the middle of the genius glossus muscle. So the whole concept of submucosal tongue tie has been thrown into question. For many years we kind of accepted it, but the anatomical studies suggest that we need to be rethinking that, and that actually what we're feeling is muscular tension and perhaps fascial tension as well, and that actually releasing the fascia and muscle by other means other than surgery may be the actual correct way to go. So with those types of tongue tie now, we tend to go down the breastfeeding management and bodywork route rather than the surgical route. But it's an evolving thing, and there's still quite a lot of question marks about the best way to deal with a posterior tongue tie. But it is actually quite a difficult concept to get your head around, and even as professionals who divide tongue ties, it does get quite confusing and quite complicated.